My name is Jerry Abraham, and I'm a GE NMF Primary Care Leadership Program Scholar from the University of Texas School of Medicine in San Antonio. I worked at the Franklin Primary Health Center in Mobile, Alabama. My research focused on the National Center for Quality Patient-Centered Medical Home Model Recognition process and the challenges federally qualified health centers face when applying for this designation. The objective of this research project was to assess the preparedness of the Franklin Primary Health Center for NCQA patient-centered medical home recognition, particularly Level 3. The methods of this research project was to identify components that require additional improvement for the NCQA PCMH application, analyze federally qualified health center performance data, design and test an intervention to improve improvement variables such as no-show rates, patient wait times, and patient satisfaction. Key findings of my research project include the areas for improvement identified included assessing patient management goals, improving utilization of electronic health record data, improving health literacy, improving patient satisfaction, improving scheduling protocol, and improving workflow patterns. Additionally, other areas for improvement include reducing patient wait times, reducing patient no-show rates, and increasing provider productivity. The analysis showed that 60% of patients at Franklin Primary Health Centers across their 24 clinics had a 60% attendance rate on average, 10% canceled, and 30% of patients did not show for appointments. Additionally, patient satisfaction survey data showed that 45% of Franklin Primary Health Center patients were highly satisfied with the care they received, with over 75% of patients showing that they demonstrated some form of satisfaction from the Franklin Primary Health Center. Only 4% of patients were poorly satisfied. Recommendations from this study include personal telephone call reminders to patients help reduce patient absenteeism. Reducing patient wait times is the most important variable in improving patient satisfaction. Furthermore, continued capital investments in health information technology will continue to be the best investment with the greatest return for community health centers. Additionally, forging partnerships and affiliations with academic medical centers, hospital systems, and large specialty groups increase the fluidity of the care continuum and the total number of providers patients have access to. This is the most important, significant predictor for whether or not a practice can achieve NCQA patient-centered medical home recognition. In conclusion, 75% of federally qualified health centers have achieved NCQA patient-centered medical home Level 3 recognition. Therefore, it is imperative that the Franklin Primary Health Center diligently work to obtain the same designation in order to competitively compete for various incentives, financial and other resources that will be available to community health centers in the future as healthcare reform continues to unroll. This will empower the Franklin Primary Health Center to do more to improve the health of their patients and the community that they serve in Mobile, Alabama. Thank you.
Hello, my name is Anna Herring. I'm a fourth-year medical student at the University of Texas School of Medicine in San Antonio, Texas. I was placed at Centro Med in San Antonio. My project was titled An Effort to Increase Enrollment in Cancer Screening Procedures. By working at Centro Med, I learned that there are grants available to help an unlimited number of uninsured and underinsured patients receive cancer screenings. However, many patients are not getting referred for the procedures in the time frame that is recommended. My objective became to increase preventive care utilization among Centro Med patients, with a focus on mammograms, colonoscopies, and pap smears. I accomplished this by working with my site mentor and a site nursing leader to create a pre-clinic form that can be filled out by triage nurses during walk-in clinics. This form shows when each of the procedures were last done, the results, and the recommended screening interval. This will help notify the provider that the patient is due for their next cancer screening procedure. It will also give the provider a chance to discuss the previous results with the patient if they had not been informed already. This form will then be sent to a care coordinator at the end of the day so that the patient can be called to schedule their appointment for the specific procedures. There are no key findings since it will take a year before we can see noticeable results. I would recommend that CentroMed figure out the percentage of patients that currently meet national screening guidelines and compare this with the number of patients that meet the guidelines in a year to prove that this process is efficacious. Overall, I enjoyed working on this project because it showed how something as simple as a form and a phone call can make a big impact on patients' health. It also showed how important it is to have optimal communication between all employees of a community health center.
Hi everyone, my name is Mary Cothey and I'm currently a second-year medical student at the Commonwealth Medical College located in Scranton, Pennsylvania. This past summer I had the pleasure of working with Adelante Healthcare in Phoenix, Arizona. My project, Raising Decibels, was all about engaging the deaf and hard of hearing community at Adelante Healthcare. I was initially presented with a document from the State of Arizona Office of the Attorney General Civil Rights Division and asked if I could assist. A deaf patient of Adelante Healthcare had filed a formal complaint with the Attorney General, which had been settled in mediation. The objectives of my project was to ensure Adelante Healthcare was in full compliance with the points of the mediation agreement and to improve Adelante Healthcare services and support to the deaf and hard of hearing community at all levels of patient contact. The project was completed in stages over a period of 7 weeks with support from Sean Furman, a deaf specialist at the Arizona Commission for the Deaf and Hard of Hearing, and Marianne Stepko, the assistant principal of the Scranton School for the Deaf and Hard of Hearing Children in Scranton, Pennsylvania, as well as discussions with Adelante Healthcare site leaders, administrators, and call center representatives regarding the management of the deaf and hard of hearing patients. During this period, I coordinated two 2-hour healthcare provider curriculum trainings, a deaf and hard of hearing sensitivity training provided by Sean Furman for all Adelante employees. I compiled a list of American Sign Language course offered in the greater Phoenix area, and I contracted an additional American Sign Language agency to provide American Sign Language services to Adelante patients. I created a protocol for the management of deaf and hard of hearing patients, and I collaborated with information technology to identify and track hard of hearing patients in Adelante Healthcare's electronic health record system. Over this period, I discovered there was a general lack of knowledge regarding scheduling and confirming an American Sign Language interpreter at Adelante Healthcare. In addition, physicians and medical assistants were unaware of a way to identify and track a deaf or hard of hearing person in the electronic health record system. In the future, Adelante Healthcare should hold yearly training sessions on working with interpreters. And Adelante must identify all of their deaf and hard of hearing patients in the electronic health records, as well as document each patient's preferred method of communication. After a formal complaint was filed against Adelante Healthcare, the organization was determined to improve its support and services to the deaf and hard of hearing community. I had the privilege of helping Adelante Healthcare make organizational changes that promote effective communication and patient-centered medicine. Thank you for your time.
Good afternoon, everyone. My name is Michelle Lagua, and I am currently a graduate of the USC Tech School of Medicine Primary Care Physician Assistant Program. As a General Electric National Medical Fellowship Primary Care Leadership Program Scholar, I was assigned to AltaMed in East Los Angeles for my externship. There, I worked with Vilma Andari, the Director of Obesity Management Programs. We evaluated the effect of their new childhood obesity program at the clinic in Boyle Heights. Solutions and Treatment in Obesity Management and Prevention, lovingly known as STOMP, was designed to emphasize the importance of parent participation in a childhood obesity treatment plan. This program was modeled after the original childhood obesity program pilot that AltaMed had implemented in Santa Ana. The difference between this particular program and the one in Santa Ana is that parent information and biologistics were tracked alongside their child. Body mass index, or BMI, was tracked and analyzed for both patients and their parents during a 12-week educational and exercise intervention. Measurements were taken at the initial enrollment of both child and parent, again at the 6-week midpoint, and then finally at the 12-week conclusion of the program. Parents underwent patient education on diet and healthy lifestyle choices, while children participated in weekly exercise sessions. Sessions were provided in both English and Spanish to ensure complete understanding of the intervention. Moreover, both parents and children signed a contract to complete certain homework assignments and commitments as well. This included daily exercise programs, restriction of time in front of the television, limitation of meals outside of the home, elimination of caloric drinks, and a commitment to lose a certain amount of weight by the end of the intervention. Along with these commitments, families were required to attend all information or educational sessions. Families were disenrolled if more than one session was missed during the intervention. The participants ranged anywhere from 6 years of age to adolescence. A total of 24 families were originally enrolled in the program at the beginning of May. 7 families were disenrolled from the intervention due to attendance. Of the remaining 17 families, 6 children were monitored from the 6 to 8 year age group, 8 children from the 9 to 12 year age group, and 3 children from the 13 plus year age group. At the 6-week midpoint check-in, there were significant changes in body mass index, found both in children and their parents. More importantly, there seemed to be a direct correlation between the change in a child's BMI with their parents' BMI. This validated the importance of seeking parent participation when designing and implementing a childhood obesity intervention. Recommendations were to make parents more accountable for not only child, but entire family participation in an obesity management and prevention program. Surveys should be distributed to determine the parents' attitudes toward and perceptions of the program in question. It would be wise to evaluate any perceived barriers to effective intervention as well. Participation from parents is a key determinant in the effectiveness of any childhood obesity management program. Future programs designed and implemented by Ultimed will monitor both parents and their children's biologistics throughout the intervention as a result of this study. Thank you guys for your time, and if you have any questions, feel free to email me at Michelle, MICHELLE .lagua, LAGUA, @gmail.com. Thank you again.
Hello everyone, my name is Daryl Nowaki. I am a second year physician assistant student from Chatham University in Pittsburgh, Pennsylvania. For the PCLP, my placement was in San Antonio, Texas at Centro Med. During my time there, in conversation with the clinical director, I decided to work on and evaluate their no-show rates. Central Med was running at a 30% no-show rate when I arrived, right around there, and obviously this is seen as a problem since the national no-show rate is around 5%. So the objectives that I was looking to do is to find ways to improve this no-show rate through awareness of the problem, examining why patients don't come, looking at the appointment reminders, and take a look at improving wait times and patient flow. In order to do this, I looked at online research at what other clinics have done. I looked at what Central Med is currently doing and analyzed cost versus possible benefit of implementing these changes. Now, looking at what other clinics have done, I went online and did research through journals and saw what articles were published referring to improvement of no-show rates, as well as some websites that were dedicated to different strategies to improve no-show rates. In this time, there are many suggestions that included different appointment reminders, charging fees for missed appointments, dismissing chronic offenders, as well as looking at the flow studies throughout the clinics or the offices to improve patient wait times and really give a better customer service satisfaction feel with each appointment. When patients are looking at when they come to the clinic, they really need to know why they are returning to the clinic, and making sure that this education is given to them so that they know the importance of showing up for their additional appointments. Also, the clinics or offices with the best no-show rates carried out several strategies of appointment reminders, including mailers, phone calls, and if they did miss, follow-up phone calls to find out why they missed their appointments. Additionally, if patients spend less time in the waiting room and are seen quicker, they know that there's a set amount of time that they will spend at their doctor's appointment and don't have to miss a half a day or even a full day of work or school. So the recommendations that I'm making to Central Med are, first off, to change your automated calling to the evening. Right now they work on an automated calling that starts at 8 a.m. and usually lasts until around 1 p.m. before all their calls are made. During this phone call, it goes out through an algorithm that the computer detects whether the phone call is answered or whether it goes to voicemail. If it's answered, the patient has a selection to choose in English or Spanish, their reminder. But if it goes and is detected that it picks up a voicemail, then it goes through their time, date, and location of their appointment in English and then in Spanish. And with Central Med being in San Antonio and having a large Spanish-speaking population, it is important to have the Spanish done up front. So this was another recommendation, that they could actually pre-select the language when the patient makes the appointment or sets up the appointment, so that whatever reminder they decide to use, whether it be voicemail or calling, email, texting, that it goes out in the preferred language of the patient. Also, it's an advantage of the automated system that they can have the calls go out whenever they want, so they have the opportunity to make them in the evening without needing to use resources such as personnel to make the phone calls. And when they go out in the evening, they're more likely to find patients at home between 4 and 9 p.m. Adding a postcard reminder was another recommendation, as patients can change their number, text with the changing of track phones, or don't always check their voicemails, where not many people change their address, and adding a postcard reminder seemed fiscally reasonable as well. In identifying why patients miss their appointments, this would add some onus to the practitioner to make that phone call afterwards and say, hey, why did you miss the appointment, and try to either, that gives an opportunity to reschedule an appointment or to find out the condition of the patient. Also, just improving customer service. As the change in healthcare comes, patients are going to have more options, and you need to be customer friendly, door to door. to attract those patients and keep your patients. And additionally, like I talked about before, decreasing the wait times through flow studies could also help. Overall, my time at Central Med was great. I really appreciated the clinical experience as well as the leadership activities, and I really would like to thank the GE and MF and the scholarship program that made this possible for me to have this great opportunity.
Thank you for taking the time to listen to and review my executive slide from my experience as a PCLP scholar in the summer of 2013. My name is Stephanie Oji, and I am a second-year medical student at Morehouse School of Medicine. During this past summer, I was able to spend my 6 weeks at United Neighborhood Health Services in Nashville, Tennessee. During my time there, I implemented a project in hopes of improving the health literacy of the patients in United Neighborhood Health Services. That leads to my title of my project, Increasing Health Literacy Among Patients, the United Neighborhood Health Services Resource Book. The reason why I find health literacy important is studies show that a lot of the diseases that are prevalent within the United Neighborhood Health Care community, which are diabetes and hypertension, are correlated with health literacy. And let me define health literacy as a degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Now, studies show that limited health literacy skills are associated with chronic diseases such as diabetes and hypertension, as well as poor maintenance of these diseases. So therefore, with the high diabetic population that is seen at United Neighborhood Health Services, increasing the health literacy of their patients could actually increase their management of these diseases and the overall health of the population. That is why I was interested in completing this resource book for this particular community. So when I got there and received the okay, I decided to, come up with an objective to spearhead the project, which is listed here on my slide, just to increase the health literacy amongst the patients by creating a resource book that would be used during the patient and clinician or patient-employee interaction at the center. The book started off as a resource to be used within the diabetic population specifically, but it later ended up being to include all patients, not just people with diabetic needs. In order to get this book done during this small period of time that I had within the community, I had to attend several meetings between the site leaders as well as my mentor at Meharry and Vanderbilt Alliance. At these meetings, I received feedback pertaining to the gathering and the organization of the information and organizing the book in a way that would be most accessible to both the clinicians as well as the other employees at the centers. And I also took the opportunity in the time within the community to collect information about the different topics that would be included in the resource book, including general cost assistance. That was more specific to the insurance plans within the area that are offered to people at low income, who receive low income, as well as dental services and food banks and things of that nature, which can improve the health literacy of the patients. And these are all targeted, or these all are specific towards people who have limited income. So after completing these meetings as well as gathering this information, I was able to compile a resource book which included 33 affordable resources within the Nashville area, as well as information of the Affordable Care Act. With the marketplace opening in October, I believe that information was necessary to be included in that book. And that book was actually placed at all of the United Neighborhood Health Services within the community. Those are 9 of the clinics within Nashville have a copy of that book to be used by the clinicians and the other workers within the clinic. And recommendations for the future, I would hope to just continue adaptable and a brochure that can be taken by the patients. During this time, I learned a lot about working in community health. I learned a lot about working in community health centers, and it really did push me to be more involved in the community. I saw that there is a great need for organization because there were a lot of resources within the community that were available. However, there was not a single place you could go to collect all of the information within the community. So that's why I was very glad that I was able to implement this book in the short time that I had. I thoroughly enjoyed my time in Nashville, and I thoroughly enjoyed the opportunity that was given to me by PCLP, and I really look forward to just meeting more PCLP scholars as well as networking within this tight community, and hopefully visiting Nashville in the future next summer to complete as well as build upon this project. Thank you so much for your time.
Hello everyone, my name is Tem Waldesus. I am a second year medical student at the University of California, San Francisco School of Medicine. I was fortunate enough to be placed at West Memphis, Arkansas at the East Arkansas Family Health Center. So my site was very enthusiastic with having us get the most out of our PCLP experience. The senior leadership were very open and let us PCLP scholars into all of their administrative meetings. After attending their monthly continuous quality improvement meetings, I observed that the EMR system that they had recently implemented was not being used to its fullest capacity. In the evaluations of clinical operations and the variables tracked in their EMR had the potential to be expanded upon in evaluating provider performance. I also observed that the patient cycle times were not being evaluated monthly, despite patient satisfaction surveys suggesting cycle times were prolonged. So given that, I tweaked my previous proposal on no-show rates and really wanted to develop a model for analyzing patient cycle times at East Arkansas Family Health Center using data tracked by their EMR to evaluate provider and clinic efficiency. So I, en route of developing that project, I had to generate the EMR data. So they had a solutions tool attached to their program called Bridge IT. And I had to set a date range to pull all of the patient encounters. And I set the date range from December 1st, 2012 to July 1st, 2013, and that generated 44,000 data points. A lot of these data points were incompatible, meaning they had cycle times that were shorter than 8 minutes, missing patient arrival and departure times, and some had missing provider labels, like which provider the patient was seeing. So after adjusting and filtering those points, it got me to a total of 4,497 data points. And then I organized the data by provider, date, site, and then I analyzed it by calculating the cycle time, which was the time when patient arrived in the clinic to when they walked out of the clinic. So I calculated that, and I also did cycle time encounter groupings. And I also calculated the duration from their appointment time to when they left the clinic. I then filtered the tardy encounters and then repeated the analysis I did in the previous step. So I calculated the cycle time averages for all of the providers at each of the 5 sites. And then I grouped the cycle times based on their duration. So whether I counted the amount of encounters that were within 0 to 30 minutes, 30 to 60 minutes, et cetera, et cetera. And then I plotted and represented the data. And so what I found was that the cycle time goal published by other CHCs and the literature of family management, East Arkansas Family Health Center has not met the goal on 79% of the encounters. And the common cycle time goal was 60 minutes per encounter. So East Arkansas Family Health Center had an average cycle time of 99 minutes, with significant variances across all their sites. And outstanding encounters were defined as encounters with cycle times above 2 hours. So they had 1,295 patient encounters over the course of 8 months that were longer than 2 hours. And I also figured out that the variables that are generated by Bridge IT and are tracked by their EMR system can serve as a great tool to evaluate their clinical operations. So for my recommendations, the EMR check-in and check-out times that I use to calculate the cycle times that are recorded by the front desk administration should probably be enforced. Just so that there's higher confidence in the values, and that each provider be matched with the nurse so that this team can examine their cycle times and manage their own bottlenecks. So it kind of would narrow in the focus of the obstacles in having a very short or brief cycle time. I'd also recommend using monthly performance dashboards and efficiency evaluations with continuous goals and aim setting, just so that people, so that providers, after knowing their benchmarks, have a plan and a goal for the next month that they can strive for in order to be continuous improvement in their cycle times. So that was a sum up of the project that I did over the summer. And I have to say that my PCLP experience was easily one of the best experiences that I've had as a medical student, or even a student for that matter. And I was extremely interested in the mission of the PCLP program when applying for it 8 months ago, and felt that the experience that I received was well above what I can even imagine. So I'm very grateful for the staff and some of the fellow scholars that were with me at the site. So thank you for listening. And if you have any questions, please do email me. Thank you.